Good afternoon to everybody joining us today for the last webinar in this Experts on Air series. My name is Caroline Brown from Hamilton Medical, and I'm very pleased to welcome back two of our special guests, Professor Jean-Damien Ricard from France and Dr. Oriol Roca from Spain. The topic of today's discussion is the use of nasal high flow therapy outside of the ICU. I'm pretty sure you're all familiar with the format by now, but just in case there are any new participants joining us today, your cameras and microphones are switched off, but you can ask as many questions as you like using the Q&A function. The session is being recorded and you'll receive a link to the recording a few days after the event. And now I'm delighted to hand over to Dr. Oriol Roca, our interviewer for today. Thanks, Oriol. The stage is yours.
Thank you very much, Caroline, and hello, everyone. Thank you for joining us in this last webinar of the series about high flow that Hamilton has promoted. I'm very happy to share this webinar with Jean-Damien Ricard. Hello, Jean-Damien.
Hi, everyone.
Hi. Jean-Damien is a full-time professor in intensive care in Paris University. He's the head chair of the ICU in Louis Mourir Hospital, which is part of the Greater Paris Consortium of hospitals in the public assistance of the Paris hospitals. One of his areas of research is management of acute hypoxemic respiratory failure, and he has been studying nasal high flow for over 10 years. He has participated in the panel that published the ICM guidelines on nasal high flow. Well, before starting with the presentation and the discussion with Jean-Damien, I would like to launch two questions that will let us know how is people thinking about the topic that we are presenting today. The first question is the one that I hope that you can see in your screens, is the maximum FiO2 in nasal high flow that you may use in the ICU. So please vote, and we will comment the results after your votings. Increasing. So it seems that in the middle is the right thing. Let's see what the people think. 20 seconds more, and we will show the results to the audience. Once we arrive to the 70% of participation, we will close. So 2 seconds, last, finish. So these are the results. Most people think that around 60% should be the threshold about limiting the high flow therapy in the ward. What do you think, Jean-Damien?
Yes, thank you, Oriol. Obviously, there's no exact answer. It depends how you are organized, but I quite agree with the audience. I would have answered that the 60%. I think it's reasonable, it's safe. Obviously, the idea is to have a margin in case the patient worsens and you have time to bring him to the ICU. So I think it's a reasonable cutoff value.
Okay. And the second question is about monitoring high flow and the frequency of monitoring. When treating patients with high flow outside the ICU, how often you check them? So some seconds to vote, and let's see the results. Almost 70%. Let's see, 10 seconds and we end the poll and share the results. Okay, 3, 2, 1, and that's all. So these are the results. Every 2 hours and every 4 hours are the results.
Okay, I think there again, it depends on the severity of the patients you're having on the ward. Obviously, if you've accepted a maximum FiO2 of 80%, then you'll have to have a much closer monitoring than if you've limited the FiO2 and the flow to a smaller value. And there again, it depends how far these patients are from the ICU. But I think that every answer was correct there again, depending on how you organize. But clearly, close monitoring of these patients is mandatory.
Thank you, Jean-Damien. So I think that we could go to the presentation before the discussion. So the floor is yours, Jean-Damien.
Thank you very much, Oriol. Here we go. There we are. So thank you very much for this kind of invitation. It's a pleasure for me to be here with you this afternoon and to discuss the use of nasal high flow, obviously outside the ICU. Here are my conflicts of interest. And so the background to this talk is obviously we're all experiencing an increase in the use of nasal high flow, whether it's in the ICU, in the OR, or in the ED. It's already very simple setup and it's a user-friendly device. There's generally a very good acceptance by the nurses. We had published a small survey on that. In fact, there's little surveillance required in these patients. I think there's sufficient data to say there's a true efficacy in alleviating respiratory distress and improving oxygenation. And so obviously it's very tempting to use the device outside the ICU for all these reasons. However, I think we need to bear in mind the fact that there are potential drawbacks to the use of nasal high flow outside the ICU. We alluded to this in this editorial we wrote with my colleague Jean-Damien, there again highlighting the potential dangers. We were, I think, first given this notion of the hazards of nasal high flow by this publication, which is 5 or 6 years old now, published in Intensive Care Medicine, and these authors compared all those patients that had received nasal high flow and that had failed, so they required intubation, and they classified these patients according to the timing of intubation. Either it was early, within the first 48 hours, or it was late after the 48 hours. And as you can see, there was a striking difference in terms of mortality. It was less than 40% in the early intubation, but it was 60%, 66% in the late intubation. So a tremendous difference, thereby highlighting that timing of intubation was critical in these patients. However, and it wasn't very clear in the manuscript, but we could understand, in fact, that all these patients had, in fact, received nasal high flow outside the ICU, and they were admitted to the ICU when they required intubation. So this gives us an idea there too of the use of nasal high flow outside the ICU, and having a look at how what is their outcome in terms of intubation timing. And as you can see, when you look at the patient's characteristics, there was a striking difference in the number of hours of use of nasal high flow before intubation. Remember, the cutoff for classifying these patients was 48 hours. But in fact, when you look at the figures, those that were intubated early were intubated only 10 hours after the use of nasal high flow, whereas those that were classified as late intubation after 48 hours, in fact, it was much more than 48 hours. It was 125 hours. And so this is almost 5 days without being intubated, and you're in acute respiratory failure. So clearly, this is an illustration of what should not be done when using nasal high flow outside the ICU. And clearly, as we had mentioned in an editorial that accompanied this paper, I think that the device was not solely responsible for the failure of these patients. Clearly, a medical management could be questioned. So what are the potential sites for the use of nasal high flow outside the ICU? I think we can imagine at least 3 potential sites, and I would be very happy share and to have your opinion on that. Obviously, the emergency room, this is where we have the most data. The pneumology ward makes sense. And we've seen with the COVID pandemic that the infection wards and the general wards have been sites where nasal high flow has been used. And there are two ways to consider the use of nasal high flow outside the ICU, either in a pre-ICU treatment, and this is what we call ICU unloading. We try to avoid the entrance to the ICU, the admission to the ICU of patients, and also to after the ICU period. And this is thanks to the early discharge of these patients. And this is what we call ICU offloading. And there again, we can find the same sites, pneumology ward, infection, or general ward. There are some data that have illustrated these situations. I've shown you this retrospective observational study that was published last year. So it was all COVID patients that were admitted to an infection ward to receive nasal high flow because of COVID pneumonia. And there were two categories of patients, those that were in the uploading of ICU and the offloading of ICU. And they looked at the characteristics between these two groups of patients. What they found was the severity of the patients was not the same if it was uploading or offloading. And clearly those patients that were used as a offloading of ICU, so after the ICU, had a better prognostic than those that were admitted before, and in which we try to avoid the ICU admission. And clearly, the authors commented on the fact that in their opinion, use of nasal high flow was safe and feasible outside the ICU when it was after an admission, but perhaps it would be more delicate to use it as a pre-ICU admission, there again, because of the risk of deterioration of the patients and the potential and the need for close monitoring. Another illustration of the use of nasal high flow in a ward other than the ICU comes from France and Brittany. This nice study published in European Respiratory Journal illustrated how a pneumology ward organized itself to admit patients to this ward to receive nasal high flow before ICU admission in patients with COVID-19. And this obviously was at the peak of the first wave and all the ICU beds were taken. So clearly they had not any choice and they had to use nasal high flow in these patients. And they showed quite a nice result in terms of outcome. And then again, there was a close collaboration between the ICU and this pneumology ward, and I'll be alluding to this afterwards. So what are the potential drawbacks from using nasal high flow outside the ICU? If we're on the patient's perspective, obviously, and we've alluded to this at the beginning of the talk with the poll, there's a risk of insufficient monitoring. There may be a delay in recognition of worsening or failure of the device, and this may lead to delay in intubation. And as I had the opportunity to discuss this in another talk, that there is a risk of worse outcome. On the ICU perspective, there's the risk of having many patients dispatched outside the ICU, and you don't know exactly how many and how they are doing. So there's the risk of having a simultaneous, unexpected, urgent admissions. And clearly, this gives the management of ICU beds more complicated because you know that you have potential admissions outside the ICU. On a health institution's perspective, there's the fact that you may have inexperienced staff using devices they are not used to use. There may be an insufficient patient to nurse ratio. And also there's all the question of the management of devices and consumables. And obviously, we can see that whoever wants to try and institute nasal high flow outside the ICU must address all these potential drawbacks. And how to avoid them? Well, clearly, I think the training of ward staff with ICU personnel is really mandatory, and this is what we have done in our ICU. Appropriate protocols written in collaboration with the ICU team, appropriate monitoring, and we'll be able to discuss this afterwards. And again, early recognition of failure, because of the figures I've shown you with this study showing us a striking difference in terms of mortality. I think this is the key issue to identify early those patients that are failing, and at least a thrice daily update on all the patients receiving nasal high flow outside the ICU. How can we monitor these patients? The ROX index, I've already alluded to this score in a former webinar, clearly has been established by my chairman today, Oriol Roca, to identify those patients that are failing. It's a very simple score, and you can see how it's constructed with the saturation divided by the I502 and all the result divided by the respiratory rate of these patients. And we established this score in a cohort of patients receiving nasal high flow, and the score was confirmed in a totally independent study and cohort of patients, there again showing that a certain value of this score enabled to have a clear idea of those patients that would succeed on nasal high flow and those who would fail. And several studies have shown that the ROX index may be useful outside the ICU in patients receiving nasal high flow. This is an example, as you can see, when they looked at the patients that succeeded and those who failed, there was a clear distinction in terms of the ROX score. You can see the values 8.2 versus 5.1. And there again, this is an illustration on the fact that nasal high flow can help to monitor patients outside the ICU. There again, another illustration in patients receiving COVID-19, and there again, the ROX index was clearly a value of interest to help monitor these patients and identify those who would fail. The question of the threshold has been addressed in this study, and clearly this is something we can discuss afterwards. What is the precise value of the ROX score outside the ICU? This was also highlighted in this review, there again stating the fact that the ROX score was a good tool to monitor these patients. So to conclude, I think we must bear in mind that inappropriate use of nasal high flow is associated with worse outcomes, so we need to be careful of that. In the setting of ICU bed shortage, nasal high flow has shown promising results in avoiding ICU admission or delaying ICU admission when used outside the ICU. Trained personnel, written protocols, and close monitoring are mandatory. ICU teams must be aware of how many patients are receiving nasal high flow outside the ICU and how they are doing fine or not. And the ROX index may be useful to identify those patients who are failing and who will require ICU admission. Thank you for your attention.
Thank you very much, Jean-Damien. It was a very clear and nice presentation. And we will start with the questions from the poll. The first question is about the use of ROX. And it's, would you suggest using the ROX index also outside the ICU? And would your criteria for the failure be different or not?
So I showed you there several studies, I think, that have clearly shown that the ROX score is useful and may be used outside the ICU. I think because it's very simple, it doesn't require continuous monitoring, so it can be done at several time points. It can be shared on a smartphone. There are some applications that allow it to have it directly calculated on a smartphone. So I think, yes, it is really practical for the use outside the ICU. And the question of the threshold is another question. There's no study that has prospectively identified what would be the threshold. We, in the studies that we did together, we used the threshold as an intubation indicator. Obviously, when we're discussing patients outside the ICU, we want to be able to identify them before they require the intubation. So rather than having perhaps one single value of the ROX, I think it would be the kinetics of the ROX index. If it's gradually decreasing, then I think the physicians should alert the ICU physicians to assess the need for intubation or not, and therefore the admission to the ICU.
So related with that, in another question is that in most hospital wards, a pulse oximetry is the only monitoring device available. Do you recommend monitoring the respiratory rate regularly as well?
Yes, I would, but I don't think it has to be a continuous monitoring. Or I think we have some remote saturation devices to monitor the SpO2 quite easily. That they're portable, they can be displayed there again on smartphones. So this is very useful for a nurse to have the continuous monitoring of the SpO2. And I think that the respiratory rate, ideally, obviously, it would be best to have it continuously, but even if it's from at different time points, it enables to calculate the ROX, and I think this is sufficient.
Thank you very much. Another question is about the use of high flow in the emergency room, and is what do you think about the replacement of conventional oxygen therapy by high flow in the emergency room? I guess that the use of high flow has raised a lot in the ER, and this is related with that.
Of course, there is the risk because it's so simple to use and it has positive results. The temptation may be great to place it to all the patients. Obviously, there's a problem of consumables, of device. It's perhaps not necessary in all patients. And also there is the question of oxygen delivery and consumption in a hospital. And we've known because of the pandemic, unfortunately, some countries have been in a desperate lack of oxygen. We saw these images in India. So clearly, I wouldn't promote the use of nasal high flow in every single patient that requires oxygen in the ED. However, I do believe that as soon as a patient requires more than 9 or 12 liters with a face mask, then I think it can be really valuable for the patient to use nasal high flow.
And do you use high flow alternative with O2? Or once you try to switch to conventional oxygen, you never go back to high flow? How do you win the device?
This is a good question. I don't think it makes sense to alternate nasal high flow with conventional oxygen because of all the beneficial effects of nasal high flow, unless obviously there is a problem of oxygen delivery and the risk of shortage of oxygen. But if there's no risk of shortage of oxygen, I think it makes sense to use nasal high flow, then wean from nasal high flow, and then go on to standard oxygen. We can discuss perhaps later on the weaning of nasal high flow. There again, there's not so much data out there.
About the weaning, how do you do that? I mean, you decrease the flow up to certain level and then you try to switch. How do you do that?
So I think that because most of the beneficial effects of nasal high flow are flow dependent, there are very nice studies showing that, I think it makes sense to keep the level of flow the highest possible. So that means the highest that the patient can tolerate. And so that you first need to start by reducing FiO2. We did an observational survey of patients receiving nasal high flow. And in fact, we found that in over 200 patients receiving nasal high flow, the level of flow was changed very little during the entire duration of nasal high flow. There was just 1 or 2 changes, whereas FiO2 was changed several times with a decrease. So my bias is to decrease FiO2 up to approximately 40%, and flow doesn't really need to be decreased there again if it's tolerated. And when you're within the ranges of 30–40% FiO2, then you can start weaning and removing the nasal high flow device.
And regarding the use of high flow at home, we have some data in COPD patients about exercise tolerance or this kind of analysis. What do you think about it?
Yes, there was nice studies by Jens Braulich, who was a speaker on the webinar, and who showed that in chronic COPD patients, nasal high flow at home was as effective as non-invasive ventilation to reduce hypercapnia in patients with stable chronic respiratory disease. So I think this is a nice area for research and for patient care, obviously.
And I think there is one, I think, crucial question. Which kind of patients would you require a particular attention? Or in other words, which kind of patients would you suggest not to treat outside the ICU?
That's a very good point. I think clearly any patient presenting with an additional organ failure, in addition to the respiratory failure, clearly these patients need to be right away in the ICU. And those who have only a single organ failure, just the respiratory failure, then again, and this brings us to the first question of the poll on the maximum of FiO2, and I would suggest not having patients with above 60, 70, 80% FiO2 on the ward. I think these patients should be in the ICU because of the high risk of intubation.
And how do you, from a practical point of view, how did you organize all these high flow outside the ICU in your hospital? I mean, you teach people in the ward that once FiO2 is certain threshold above, then they should call you. The same with respiratory rate. How did you manage it?
So first we trained the nurses with our own ICU nurses so that they could discuss between themselves and use the devices and be happy with the devices. Then we had medical students that were off their duties, obviously, because of the COVID. So they were dispatched back to our hospitals. So we trained them on the devices and on the ROC score. And so these students went to see these patients every 8 hours, and they came and gave us a feedback on the ROX index of these patients. So an increasing ROX and which had a decreasing ROX, and it enabled us to prioritize those that needed ICU admission and those who could be kept on the ward. And this worked really well.
And what do you think about, because you have shown about that the timing of intubation may play a role in the outcome, but what about the chronic patient? And if you can see, you think that it can be used for a longer period of time in these patients?
Yes, obviously, we can imagine that because nasal high flow provides a much greater comfort in a different setting than the acute setting, we can imagine that patients with chronic respiratory insufficiency may benefit from nasal high flow, and so especially outside the ICU and in the pneumology wards. And as you mentioned at the beginning, exercise tolerance is much greater with these devices. So perhaps in terms, for example, of rehabilitation of patients, sometimes after an acute infection in the ICU, I think it may be very useful to have these devices outside the ICU.
And a very important question, but very important and obvious question is, how do you transfer the patients that you need to transfer from the ED or from the normal ward because they are deteriorating to the ICU? You keep them on high flow, or you switch to conventional oxygen for transferring them? How do you do it?
So we prefer transferring them with nasal high flow. Some devices have a small internal battery that enables to transport them. You obviously need to have an oxygen tank that allows you to do the transfer. But the most critical issue is the distance. Is it 2 separate buildings? If it's just a question of 1 or 2 floors, well, then obviously the patient can do without an active humidification during this this very short period. So there again, it depends on exactly how distant is the ward from the ICU. But clearly we try and keep them on the nasal high flow.
And what do you do with do you decrease the flow because you have problems with the humidification, or how do you do that? Because some devices, you have to turn it off, the humidifier, and then the patient maybe they do not tolerate so higher flows. In this case, you decrease the flow?
Yes, that's a good point. If the distance between the ICU and the floor is big, and if the flows were very high, then clearly even in a couple of seconds they may not tolerate the very dry flow. So in this case, it makes sense to decrease the flow. from perhaps 60 to 40 liters a minute. And as soon as they're back in the ICU, we can increase the flow.
Okay. And there's another question about the use of high flow with 21% of oxygen in case that you don't have any connection to the flow, connection to the oxygen, sorry. So what, could you comment something on that?
Yes, well, there's 2 points. The first of all, I suspect that patients with hypoxemic respiratory failure will require some kind of increase in HFO2. So 21% is rare, and that is not sufficient. But there's also too, as I mentioned already, the impact of the flow and the level of flow. And we know that the PEEP effect, the washout effect, that can be done in a 21% FiO2. So I wouldn't be as drastic as 21%. I think we need a little more, especially in patients that are hypoxemic, but clearly in some of the patients, if already we have a very increased flow, this is already something that's better than nothing. But bear in mind the fact that these patients are very often profoundly hypoxemic, and you will need greater than 21% FiO2.
And Jean-Damien, do you have any experience with combining high flow with the use of inhaled medical gas?
No, I have not. We do use them with aerosols from bronchodilators, for example, and there are data in the literature indicating that not only it's beneficial, it's safe, so we can use that. But on the medical on the other gases that were mentioned in the question, the question, it was nitric oxide, for example, or helium, and I don't have any personal experience. And to be honest, I don't recall any specific publication on these devices. There's clearly a security issue with these gases that will be given also to the nurses and to all the healthcare providers around in the room.
And I think that we have time for a couple of more questions. One is regarding the nebulization that you have mentioned now in your answer. How do you do that in the hypoxemic patient? Because we know that maybe decreasing the flow will increase the position of the drug in the lung, but the flow is, the effect of high flow is flow dependent on the other side. So how do you do in your clinical practice?
So yeah, it's a very good point. You need to find the best compromise. As you mentioned very clearly, increasing the flow will increase the impact of the droplets on the upper airways, so decrease the deposition in the lung. So what we know is you must not use the aerosol just at the patient's airways, and so you need to place the reservoir just at the exit of the chamber of the humidifier and the high flow device, and this is the best way to have an ideal deposition and the droplets that will go the furthest possible into the lungs, but clearly not right at the nair.
And there's another question about the use of high flow in prone position.
Well, clearly it should be done, and I think it should be suggested and proposed to every single patient that does not require immediate intubation. And you participated to this very nice meta-trial showing that the use of prone position in spontaneous breathing patients, and most of them were receiving nasal high flow, if not all of them, showed a reduction in intubation in these patients. So clearly, and that was very true for COVID patients. I think it's interesting to see if this is confirmed in non-COVID hypoxemic respiratory failure, but clearly I think it should be suggested to all the patients, there again, depending on their tolerance. Just one important part on this question. In the study I've just mentioned, it was shown that patients had to receive a prone position for at least 8 hours. There was a clear benefit after 8 hours of prone position, not continuous, not necessarily continuous prone position, but a cumulative time of 8 hours.
Thank you very much, Jean-Damien, for your answers. It has been a pleasure to share with you this webinar, and I would like to thank you again to Hamilton for organizing this webinar series on high flow. And thank you, Caroline, for everything. The floor is yours.
Thank you. That's a wrap, everybody, and the end of this series on nasal high flow therapy. On behalf of Hamilton Medical, I'd like to say a huge thank you to all the experts who've contributed their time and knowledge to this series, and of course to all of you for taking part. Watch your inbox early next week for the link to the recording, and our next Experts on Air series is not too far away, so watch out for that on social media and our website, or you can sign up for our events newsletter using the link that's been placed in the chat. Goodbye, everybody. Thanks again very much, and hope to see you again soon. Bye-bye.